If you look at the history of hair restoration, it started with something funny. Camel excrement, 5,000 years ago. In fact, if you look at all the stuff we do today on the internet, it's pretty close. The modern era, I believe, I give Deffenbach, a Prussian surgeon, credit. He transplanted feathers and hairs from animals. But the modern era began in the 1940s in Japan. And you know, in Japan, they have a shameful barrenness to the pubic area because they do public baths. So pubic hair transplantation was the first modern grafting that was done. We probably look at the father of hair restoration as Norman Orentreich in the 1950s in New York with punch grafting. Obviously, today, we have more of a problem with looking at those early efforts because they are more grafty or pluggy or artificial. The modern era really began in the 1980s with Headington's seminal thesis on follicular unit grafting and understanding what is the follicular unit. If that is not clear to you, it will be in a moment. What happens with hair growth and loss? We have to lose about 50% of our hair before we can even recognize that there is something going on. So that's a lot of loss before we even recognize that there is loss to be had. What happens is the growth phase, the telogen begins to, the loss phase, the telogen begins to surpass anagen. That's one of the telltale signs that you're on the process of losing hair, and you see more shedding than growth. Dihydrotestosterone, or DHT, effect on the frontal temporal hair is also important. And that's what Propecia or finasteride addresses to correct. There is not just a loss of hair. The hairs become wispy and thin, and those hairs are called vellus hairs or baby hairs. And those baby hairs are on the way out. So what is a follicular unit? This is the most important slide. If you don't understand this, you can't understand anything from this point forward. It's that our hairs are not grown in individual single hairs. They're grown in clusters of 1, 2, 3, and 4 hairs. And this is the standard of grafting, is using these follicular units and taking each follicular unit as a transfer unit or a graft. I want to introduce a more advanced topic. If you are going to start hair restoration, do not do this. This is a very advanced topic. It's multiple unit grafting. It is basically using 2 to 3 follicular units in one graft, in one single graft, and transplanting that. You say, well, is that a plug? Absolutely not. You have to know how to graft that well and select your candidate well. But you can get tremendous density in one session if you know what you're doing, and I can get tremendous density in one session. I'll show you my results down the road here. So what the multiple unit graft does is it provides a tremendously higher perceived visual density in really 1 to 2 sessions oftentimes. But you got to pick your patients carefully, and you've got to be able to technically execute that procedure beautifully. So what is a plug versus a mug? A plug is a terrible term. It was the large 16 to 20 hair grafts that were round, that were sticking out, that anyone could see from a mile away, that were positioned poorly. A mug essentially is a vertical or a longitudinal positioned graft that's much, much smaller and tightly interlocked behind rows and rows of follicular units. It is a completely different animal. And if you can't understand how to do this, it's okay. I just want to introduce the concept to you because it is an advanced topic, and most hair restoration surgeons don't know how to use mugs well. So let's start with just evaluating a patient. Patient comes into your office. What are you wanting to look at? The age is very important. You see a 20-year-old come into your office, you have an ethical responsibility to look at what your transplant is going to turn out to be in the next 20 to 30 years. You don't just transplant a low hairline and then watch everything recede behind that. Be very careful and be very ethical. You've got to look at what the medical potential they can have in terms of treatment. And I only use FDA products. I'm going to talk to you about that in a moment. But also find out what they did. What attempts do they have? Hair system, because if they're using a hair system, that's a lot of hair that they get. And a hair system, by the way, is a toupee, if you will, for the common language. But that has a lot of density, and to match that density is a tougher order if they're used to that. So you need to find out where their expectations are. And you got to look at the rate of loss. If they're in a rapid progression of loss, you've got to look very carefully at that and find out, are they stable enough to transplant, and should you wait? This is just a very broad overview. It's not meant to go through all the nuances, just to introduce the concepts. So look at, and then do your physical exam like you would any other time. Look at that recipient site. Are they terminal hairs, or are they vellus hairs? Are they little baby hairs that are on the way out? That's very important. Look at how the pattern of the hair grows, and look at the extent of the hair loss in that area. And then, where are you getting the hair? From the donor area. Remember, the whole principle of hair restoration is to take hair from an area that even in the baldest individual, they still have enough hair, they won't lose that hair, and that hair gets moved to a zone that they will lose it, and it retains the characteristics of the donor hair. Now that may be obvious to a lot of you, but if it's not, that's the principle of modern hair restoration today. And look and evaluate that donor hair and make sure you have enough density, that the scalp is elastic enough, and that you look for previous scars and see if you can help that as well. There are really only 2 FDA-approved products out there for improvement of hair loss. They do work well. I always say 70% of your result is from Propecia or finasteride. And it's easier to maintain. If you're not compliant, you don't get a result. Rogaine you got to use twice a day. Although recent studies have shown maybe even once a day is okay. But one's a topical, minoxidil, over-the-counter in the United States, and Propecia is a prescription pill that you take once a day. And here's the thing. You say, well, what is the role with medical support if you're going to do a transplant anyways? Remember one thing. Hair loss is a progressive disease. What I give you is permanent, no question. However, you continue to lose hair. I want you to regrow and stabilize your existing hair so that whatever I transplant looks even better. And that way you have fewer transplants and a fewer need for those transplants down the road. So how do you plan this? You know, this is the problem. You've got an ever-shifting canvas of loss, and you've got a limited donor supply. And you've got to figure out, based on calculations, that projected loss in the next 20 years. What I always try to help people figure this out is target your major aesthetic area. That's your hairline and your mid-scalp. That's the area where if you're sitting and talking to someone, that's what they see. The crown is not quite as important. Plus, if you develop a crown here and you got this loss, it doesn't look natural. Plus, the crown is progressive. So I usually don't like to touch the crown until I get that area stabilized on medical management for at least a year or 2, maybe even more. And that's based on patient compliance as well. They can stop doing it, and you got to talk about that. The hairline design. So many fake hairlines out there. I'm going to show you a lot of correction work, but the beginning is to find that anterior lowest point, which is a point of transition from the vertical to the horizontal plane. Anything lower than that is a good chance to have a fake result. So that is the lowest acceptable point. I even sometimes go above that. And sometimes I just do a little widow's peak to push that visual hairline down without necessarily making the whole hairline down. That way you conserve grafts and you plan for the future. And then the hairline, remember, what is a comb over? A comb over is someone combing temporal hair over to the center. So anything past the lateral canthus has got to be interpreted as temporal hair. You have to build it differently. So the hairline starts and stops at the lateral canthus. The lateral canthus are your lateral defining borders for your hairline design. I'm not going to go through all the ways to design it. But just as an idea, there's more of a bell curve suppressed look for someone with a slightly narrower head. So this is the level of artistry you've got to execute. When you're looking at someone, design a hairline that's going to match their face and their progressive loss. The other thing from a lateral view, the hairline design has got to be upward sloping in most cases. A flat design is quite aggressive, and a downward sloping is unnatural. So look at your hairline from all angles. That's important. After the hairline is designed, we shave the occiput, and that's the area we're going to harvest from. I love intravenous sedation. Because I have a surgery center, my patients don't have discomfort, and that's a rarity. If you do it under local, there's discomfort. I mean, there's just no way you're going to get around that, but we don't have discomfort. I put a little recipient site tumescence, which has a little Kenalog, and what that does, people have shown that the number one reason you can minimize postoperative edema is a little steroid in the recipient bed and a little epinephrine. So this prepares the bed during my time of harvest. So just about 10 cc's along the hairline. I sometimes put another 10 cc's into the central mid-scalp just to get that tumescent, get that bed ready, prepared. Now here's a trick. Take your time with the harvest. You've got to do that for a lot of reasons. But I like this little analogy with the ship on the Corals Sea. I use a lot of tumescence, probably 150 to 200 cc's, and I take my time and I push that scalp far away from two things: nerve supply, blood supply, so they don't have protracted hyposthesia and they don't have bleeding, or very minimal so. And I take my time to do this, and I wait until that whole bed is blanched, flat, and white. Very important, it's taut. If you don't have that, don't start. You need to have that. And this is just the tumescent solution. You can email me if you want the solutions. Prior to my closure, here is the gold standard. I love this. If you guys are doing hair transplants and you're not doing a trichophytic closure, I really recommend you to do this. It's an incredible difference. You take a millimeter of skin off the bottom lip of that incision, and it allows the hair to grow through the scar. I have a hard time finding my scars, unless a patient's had maybe 5 procedures or something like that. But generally speaking, in most patients, you can't see my scars even at close range. That's what's great about a trichophytic. It doesn't take more than a few minutes, and it's absolutely worth your taking that level of care. Then I go back and reinforce that block. The same thing applies, this ship on coral, is that the tumescence, remember, I had a patient ask me, hey, Dr. Lamb, do you do this? That tapping noise, fast tapping, means several things to me. One is the doctor is sloppy, because they're just making fast sites. I make really careful sites, and you're going to see them in a moment. The second thing it means to me is that they don't give enough tumescence, so they're not protecting the blood supply below the scalp. You need to protect the blood supply. God is in the details, and these are the details I want you to think about when you think about good hair restoration. So how do you create the sites? This is the artistry. This is what I love to do. When I do hair restoration, I'm in love with it. I enjoy this exercise. It's terrific. It's not boring. You've got to keep low angles, really low angles to the scalp when you're making those sites. Do you see this patient up here is lying flat down? It allows my hand to make low angles like this to the scalp. When you make low angles, it does several things. It visually draws the hairline down. It also allows you not to see the insertion points of the graft. And therefore, it's a much more natural result than this. And you see this all the time. I'm going to show that to you. And you want them interlocked back like a row of forest trees. And I'm going to show you that in a moment. And no splaying. Okay? In other words, like a book. If you just splay those grafts out like this, you can have a complete see-through. My grafts are forward and interlocked, except for transition zones, which I'll show you. And obviously in a regularized hairline. I compare that to like a shoreline, like a little shoreline. Each zone is different. Each zone is important. The hairline, the central forelock, which is a critical aesthetic zone. Especially when someone looks at you from every frontal angle, you double your graft density in that area, you double your visual density all the way around, because that's what people see from every angle. The lateral hump, remember that past the lateral canthus, if you're restoring hair, you can't just restore the angles that look like a hairline. It's got to restore it like the temporal sweep. And if that doesn't make sense, I'm going to show it to you in a moment. And then the crown is a very complicated area to transplant. I'm going to show you those areas. So each of these have a unique pattern of hair growth, and you've got to mimic that. Now here's a schematic. I first make these sites. If I'm just using a straight follicular unit transfer, I start with the hairline, because that's my primary zone. Then I go back and I interlock the next row. Does that make sense now, the interlocking? And I continue that interlocking, and then I create these little sentinel hairs and these little irregularized hairline that really creates a natural, soft hairline. These are some of my sites. You can see how pristine they are, really angled perfectly straight with a slight bend at the transition to the temporal hair. You'll see that better with an upcoming example. Another example, the sites are beautiful. You've got to take pride in your work, and the sites are beautiful. That's what I love to do. It's not a sloppy, just shove it in there type of mentality. And that was, and I'm going to show a close-up. I don't know if you can see this, but as you get to the lateral 1 to 2 centimeters, there's a gradual shift in the hair going to the temporal zone. That is beautiful work. If you can just get that transition zone, no hair should be abruptly transitioning anywhere. They should be gradual transitions, and I'll show you more of that as we continue. When you put the grafts in, they've got to actually stay about a fraction of a millimeter above the skin, because that's, as edema settles, it settles in. Otherwise you get pitting. So my team is as important as I am. The thing that I want you to understand is that when you do a rhinoplasty, you're it. When I do a hair restoration, I'm not it. I'm 50% of the equation. My team is 50%. If the cutting is bad, if the placement is bad, the result is bad. That's important. And when you have existing hair, you can't hurt the hair. And another thing is, I see a lot of sloppy work when there's hair, people just dance around it. Well, I dance around the hair, but I still create a tight interlock grid so that even if you lose the hair, I'm still going to be able to, you're still going to be okay when you lose that hair, because I've created such a wall of hair all the way back without hurting the hair. And you can see that right here. Beautiful, tightly interlocked sites with no hair damage. That requires loop magnification. Here's a close-up view of the transition. If you look, it's all forward angled, except where it begins to blend down into the transition with the temporal hair. If you can just have that slight transition, it's just a much more elegant, much more natural result that's so beautiful. Female hairlines are different. My goodness. How come I see all these results where women have the same results as men? That's because the surgeon didn't care. There's a cowlick, a spin and a curve that I recreate. And as it blends into the temporal hair and down, the way that transitions, I recreate. I really do. And here's a close-up view of my work. You can see how the sides actually blend back and out. That matches that cowlick, so you get a feminine result. And I'll show you results at the end. But that's important. Sensitivity to every angle of hair on every part of the scalp. You can see that transition right into that temporal hair as it sweeps down and back. And if you go, well, I can't see that, I'll show you this. This is a closely shorn male, and you can see, if you don't know how hair grows, find a guy that has a closely shaved head and look at those angles, study it, and you can see how it begins to blend in and match it. When you're doing a hair transplant, this level of care is going to take you beyond all your competitors. And you can see here how that forward angle gently sweeps down to the temple. That's a temple design. Lateral hump. The lateral hump essentially is that area that's lateral to lateral canthus. That's that upper hump. You can see this gentleman that had some hair transplants. As you start losing that hump going back, you can't just put your hairline wider. That's his comb over. You need to rebuild that hump. But when you rebuild that hump, do you just make the hair sites the same as everything else? No, there's a particular pattern of growth for the lateral hump, which you should recreate. Well, what is that design? It's this. It's a gradual cascade where the hair begins to angle down and fall like this. And you can see it there. And then you can also see that gradual part at the temporal angle. Here's an example of my work. You can see that gradual transition going downward. And you can see here the transition, again going out, just transitioning downward and outward, which is really beautiful. What's the bridge? This is also known as the vertex transition point. It's the point where the horizontal scalp on the back begins to transition to the vertical. Just like what I showed you in the front, this is almost like the back hairline, if you will. And you don't want to go below that if you're not going to touch the vertex. Keep away from that. That's the upper crescent. But look at this gentleman who has alopecia, and look at the way that vertex transition point, the hairs grow. They don't just go forward. There's a gradual sloping out. It actually matches the crown as it comes back. And you can see the angles go out. So we need to recreate that if we're doing the back side. Again, this is a gentleman just with natural hair, and you can see it's not just straightforward, it just arches out like this. So that vertex transition point needs to be matched. And you can see here, this is right in front of the vertex, you can see those transitions going out. That's very, very important to match that design. The beauty of the design is what I'm in love with. Final area, crown vertex. You can see the swirl, and I create those swirls lovingly, and it has to be done that way for a natural result. This clearly is a bad job. I did not do this work. What is my work? Do you see the swirl? How it blends naturally and transitions up to the vertex transition point as it goes into the mid-scalp and beyond? All those transitions have to be perfect to make a great result. Another example. You can see the far right is where that swirl begins, and is blending perfectly with all the hairs there, and blends up and blends down. Another swirl, you can see the perfect swirl as it blends up and blends down. There are no sharp transitions. That level of care is what I'm asking you to look at, and understanding how hair grows to make it a challenge. Protect the other hair. Visualize a bald head and create even spacing. The cascade effect is how to maximize your grafts. If a patient combs this way, I'm going to place the grafts to the left, so that as he sweeps forward and to the side, I create more visual density. I maximize his number of grafts. When I'm looking at the back crown, I want to see how he parts his hair. If he's going to go left to right, I'm going to create a crown, if he doesn't have any hair there, left to right, so it sweeps down and over and creates more visual density. The upper arc is more important because that provides more visual density coming down. You can see in Asian hair it's tough to get a good result, but I get beautiful results because the angles are low and they're really natural. You can see the hairline is natural, the angles are natural, and you can't tell seamlessly with the natural existing hair. That's a comb over on the top, and you can see as we're shedding the comb over, you can see the result. And that's as much density as I can expect in a one-time session with the multi-unit grafts here. Crown work, beautiful crown work here. Female hairline, which is a beautiful hairline that sweeps over and out with that cowlick that I've lovingly recreated. And a gentleman has had a few hair transplants without the density he wants. You can see I can truly create a lot of density in this area with the stronger types of grafts, the MUGs. No hair, really, and just really getting that density with one session. Beautiful angled hairs, we're almost done. This is a natural hairline with a pubic hair growth because of bad insertion. You got to be careful with your insertion, and you can see visual density, natural hairline, and truly a recreated hairline result. Again, you see that you can see the points of insertion from trauma from the bad team on the top, and you can see I recreated a natural hairline, and you don't see that. Plus, you have visual density. Plugs with a natural hairline coming down. No hair. This is one session. One session with the mugs to get that visual density, and one session. These are all one session, by the way. One session. One session. One session. Look at this. This is a previous work by another transplant surgeon. We're not going to talk about the future considerations. We're out of time. Thank you for your attention.